Oh, okay.
Yeah, I'm going to mute the voice.
All right. Sounds good, Cats. So we will wait 2 more minutes and then we'll just go ahead and begin. Okay. Looks like my speaker's right here and hopefully everyone can hear me.
Yeah, I can hear you clearly.
Oh, good.
Yeah.
Good.
I just put my voice mute just in case something background noise happening. I don't want to happen. So.
Okay. That's
Okay.
That's very good. Very good, Cats. I am just going to flip through this for a moment and then I'll return to the beginning again. Okay, good. I found some really very good slides that I could use. All right. Almost. All right, a few more seconds. I'm just giving everybody a chance who might be coming in right on 11:45 on the dot. Okay, I think I'll just go ahead and begin. Today is a follow-up. It's a follow-up to the spinal anatomy I talked about, presented on roughly, I think it was 2 weeks ago. And as a follow-up, I think this is most appropriate, knowing that the structure of the spine, the nerves, you need to know something about some of the common injuries, okay? So this is a follow-up to that previous one. And so we're going to do a little bit of review here first, too. A little bit of review from the last one as a recap. So basically, this is a nice side view of your vertebrae, your spinal column. And it has the same divisions. The top part is the cervical, the middle is the thoracic area, and at the bottom, the lumbar area. And below that, you have the sacrum, has a couple of separate bones, and then the coccyx, which has the very tail end, literally, of your spinal column. And a few brief functions again as a recap, pardon me. It houses and protects the spinal cord. That is one of the main functions. It also protects the channels for the spinal nerves that come out from these little, if I can find my pointer here, there are these little outlets here along the side. The spinal nerves actually flow out of those. So the vertebral column also protects those channels. And of course, without the spinal column, we have nothing to support the rest of the body. And most important, the head, the skull. All right. All right, so again, we have 7 cervical vertebrae. It wasn't numbered on the last shot, but it is this time. We have 7 up here in the neck that comprise the neck. And then for the upper and mid-upper back, we have 12 thoracic vertebrae, all right? And then as we get down to the lower back, we actually have 5. lumbar vertebrae. And then we have the sacrum, which has a couple, but it's kind of a fused bone. And then you have the coccyx, which has a couple of very, very small bones, literally at the tail end of your spinal column. And incidentally, just as a recap too, the spine itself has all these projections, and for a very good reason. It's because we have ligaments, we have tendons, we have muscles that form around these bones in order to add for a protective layer. We have so many muscles that attach to these outcroppings of bone from the vertebrae that it's so important for them to be there for things like stretching, contracting and expanding, movement, lateral, sideways, forward, backward. And without those muscles and tendon connections, that wouldn't happen the way it happens for us. All right. There are some things that likely make injury to the spinal column and to the cord too, in some cases. Your occupation. What do you do for a living? Is it heavy lifting? Is there a lot of repetitive movement that requires bending, twisting, turning, pushing, and pulling? And I say that from the standpoint of being a nurse, is that one of the most common ailments for a healthcare profession in general is back trouble, a slipped disc, a pinched nerve, a bulging disc. I want to say, all of the above. Or all of the above. Yes, thank you, Kevin. That's correct. And then over time, degeneration occurs. And so very typical is this, it's a kind of arthritis called degenerative disc disease or degenerative joint disease. And you can see it in other areas of the body, like the shoulders, the hips, the knees, the ankles. So you see arthritis over time, that happens. And I'll show you some pictures of that as we go along. And what happens too is a thing called spinal stenosis. And stenosis is, I think it's a Greek term. It means a narrowing or it means a narrowing, usually of the spinal canal, the cord, or the outflowing nerves, and how much space. So that means it's a shrinkage of space. And that ends up not being good for your spinal cord. And the herniated discs, those are those shock absorbers in between the vertebra. A lot of things can happen to them also over time. An injury can cause a weakness in those discs. And depending what you do for a living, that may actually build over time until the disc not only bulges out of its place, but actually you end up with a burst of that, and the gelatinous inside of that disc actually protruding and pushing on the spinal cord or on any of the outflowing nerves, depending on what direction it goes, because sometimes the injury follows the path of least resistance. And so individuals, as we get older, mostly men too, and this is something I kind of figured, but it wasn't something I really had any stats on, but men are more prone to these kinds of back injuries than women. They represent a very large proportion of the number of spinal injuries annually. And 60% of those injuries that happen to men end up happening from some sort of traumatic fall, like a fall on the tailbone or a fall off a ladder or something like that, or I want to say a fall that basically you end up landing very hard on a section of the back the spine, the neck, the head. So a traumatic injury from those kinds of things happening. And as we get older, we're more prone. We have less of ability to correct and right ourselves before the injury actually happens. And then our bones tend to be a little bit weaker. I want to say the bone matrix is weaker due to things like arthritis, osteoporosis, and other changes that naturally happen in the bone structure. And I want to say, if you have shrinkage in those discs, if you have shrinkage, it's going to change everything above and below. There's an adjustment that needs to be made, and that adjustment sometimes isn't good. It actually makes problems in the spine even worse. And I'll leave it at that, because I'll show you some pictures as we go along that basically show you just that. Here's a nice little nifty, and this is fairly recent. Within the last 5 years, a number of the kinds of surgeries, and these are surgeries that involve instrumentation like rods, screws, plates, back cages, all the stuff that has to be put into place, in order to repair and to support the spine after a major injury. 1.62 million annually. So that's a lot. That's a lot of surgeries for the spine. So if you're a spinal surgeon, you're never out of a job. And it's kind of like orthopedics, which for Sutter, who I used to work for, it was the meat and potatoes of the hospital. It brought in a lot of money. Hips, knees, shoulders, ankles, broken bones. And then right above that, spine injuries, spine procedures, surgeries, from the base of the back to the very top of the back. Lots of money in that. I'm not saying that's great, but it just shows you there's a lot of injuries that are occurring. So in the US, in the United States, of people with back pain, 29%, this is another statistic that I came upon from this same website, 29% believe that it's due to stress, brings on back pain. Just back pain is what I'm talking about. 26% blame it on weakened muscles or strained muscles. Others blame it on their job, maybe working conditions, etc. So this is what Americans typically believe about back pain, generically. So moving on. Again, this is a little bit of a new introduction. Granted, we have the spinal column here from top to bottom, and the spinal cord function. So basically, it's a very important long piece of nervous tissue that actually branches out into all the nerves that go to different parts of the body. And this is from the top of the spinal column all the way to the bottom. And basically, this is your major sending and receiving of signals. This is the pathway, the superhighway between the rest of your body, which is considered the peripheral nervous system, and the central nervous system, which is comprises your brain and much of the spinal cord. And again, a little bit about what protects it. There's the actual spinal bones, the vertebra. You also have other structures and fluids, believe it or not, like spinal fluid acts also as a protective layer. And of course, the other things too I mentioned, like the cushions, those intervertebral discs, and then the dura. There's the dura of, there are 3 layers to that, just in brief, you don't need to know or memorize, but the dura actually covers the brain and the spinal cord all the way down. And those are protective layers as well. So your spinal cord has a lot of protective structures around it. So it's well protected, but it still gets injured. It still gets injured. So this last picture, let me go back and tell you, this is a dermatome, a picture of a person with dermatomes. And what does that mean? So the dermatomes are those areas of the body that are actually send and receive signals from the peripheral nerves. And given that's the case, you can see in purple, you have the cervical. And so guess what? A lot of this area in purple is served by those outflowing nerves from the cervical region. Here in the light green color, you have thoracic. Now, much of your thoracic area here, including your abdomen and somewhat inside of your arms, is fed by and receives signals from this region of the body. And it has everything from T2 to T12. Same with cervical, C1, C2, all the way to C6, 7. Now, getting down here to the very base of your vertebral column is the lumbar region. And you can see it covers a vast area from the groin all the way down to the feet. Very important, very important. It covers a vast region. And so when you have symptoms in these areas, it's pretty clear that there is an injury somewhere along that region, okay? And last but not least is the sacral area, very important because it feeds the areas here around the groin and genitals, as well as the bottoms of the feet, including your heels, all right? That, believe it or not, this is a solid bone mostly, but there are nerves that come right out of there are holes and outlets where nerves come right out of. So this is just basic. If you see this dermatome, this is our dermatome man. And if you look at it and you think about areas that might be injured, you can try to match those up to what nerves or what level of the spinal cord is being served there. So again, dermatome, it's an area of skin that's supplied by one or more spinal nerves. And again, there's 8 cervical nerves. There are 12 thoracic, 5 lumbar, and there are a few sacral nerves as well. But each of these nerves is involved in the process of sending and receiving sensations, signals from that particular region of the body to the brain. So if you think about it, damage to those spinal nerves is going to show pain, pins and needles, loss of sensation, weakness, paralysis in the area of the body that's served by those nerves. If that makes sense, hopefully that makes sense, because it's often used times when when you go into a physician and you're having back pain and a possible problem with a disc or nerves, they will do a thorough exam with blunt, sharp, and soft objects in order to tell, can you feel these things? Can you feel the sharp thing? Can you feel the dull thing? Can you feel a sensation of this cotton tip over this area of the body? And so they run through a detailed assessment to help them determine what's going on and from what area of the spine it's coming from. Okay. All right, come on, let's find my pointer here. So again, looking at this from a different way, without the spinal bones, et cetera, there, you can kind of see how this looks diagrammatically. And so from the top of the spinal cord, as the spinal cord leaves the brain and begins to enter the cervical region of the spine, you can see individual nerves, and it's a whole lot more intricate than this. This is just a kind of a graphic to give you an idea of of how that looks in your own body, all the way down here to the tailbone. So if we're talking about the spinal cord, the nerves, and injury, this is just a basic picture of what they call transection, meaning where there's been an injury, possible a resection, or I want to say a complete lack of communication between the layer above and the layer below in the cord. So in other words, you have no movement sensation, or maybe nothing at all below the level of that transection. Say you have an injury high up in the cervical area. Well, that means it's very possible that you will have no movement sensation, nothing below that level, no motor control, etc., below that level of the injury. And what it could result in is that you have no more voluntary movement below there, and you have no more sensation, or I shouldn't say a complete loss of sensation, but you will have somewhere between no loss and a complete loss of sensation in many cases. And some of these will end up being things like paraplegia, where you have a partial loss of a partial paralysis to a paralysis that's maybe of lower body. Maybe it's including both extremities, lower extremities. It results from a spinal cord transection, and it may occur somewhere between the cervical. If you look at it here, the higher the injury, the more severe your problems below that level of injury is going to be. Because if you think about it, you're going to have troubles with things like breathing, moving the diaphragm, digestion, movement, sensation, all of those things below the level. The higher up it is, the more ramifications that are going to be, apparent due to the level of the injury. Now, quadriplegia is, paraplegia means just partial, usually maybe lower extremities, so upper extremities you have use of, but a quad you have no use of, usually all four, none of that. So it's all four limbs usually results in a transection that's very high, like a C3, C4 level. And if it's that bad, you may end up with being on assistance to breathe, a tracheostomy, and some other form of helping you breathe. That's how serious it can be. So again, this again corresponds, it's using different colors, but if you see some of the colors corresponding to the levels here, you can see what's being affected at what region of the body. Again, this is just a rehash of what I just went over. If the injury is really high and it's got a complete transection, a complete injury, everything below that is usually gone. And, that's worst case scenario. Worst case scenario. There are partial resections, which means you may lose only a partial movement, partial voluntary sensation, movement, ability to do some things on your own. So there are degrees of that kind of resection. If that sounds clear, a complete injury is a transection. There's no communication below that level. Partial, there may be some, and there may be hope for regaining some of that ability, sensation, and movement. Now, here is, gosh, I need to be able to move this. How do I do that? Mary Lou, how do I shrink this? Do you know? I'm almost afraid to touch anything on this. Let's see if I try to thumbnail shrink this. Oh, I got it. Okay. There we go. All right, this is an important picture for you all to see. This is an MRI. This is a sagittal view, means the person was cut. Basically, the pictures were taken like a cutaway, right side, left side. And so this is what a normal spinal cord, nerves, and spine look like. All the natural curves are there. Up here in the cervical, thoracic, and lumbar. You do not see any extrusions of these discs, no extrusions on the cord. You see a clear pathway for the spinal cord and the spinal column. Everything looks great. Picture perfect MRI of the spine. Beautiful. That's what we all hope for. Now, some common abnormalities. And the reason why I show you a colored picture of this is that it actually presents a pretty good picture. The first one I want to talk about is spinal stenosis, and that's where there is such a narrowing either of the spinal cord or there's a narrowing of those outflowing nerves that are trying to get from the spinal cord out to their designated area where they feed. And so either one of those can become stenosed. And looking at this, I would say we have a problem with this disc, and it is poking out here on this longitudinal ligament right here, which is usually the one that falls behind on the posterior portion. You have a very long one here in the front and a long one here in the back, also protective. But when a disc is injured and it injures in just the right place, it can cut off signals above to the area below. So what is it? Unfortunately, we are more prone to this as we age, and things like degenerative disease, arthritis, they are a contributing factor, okay? So, and here again, yeah, I knew I heard that somewhere. I've written that somewhere down. Stenosis comes from the Greek word narrowing, okay? That's where it comes from. Causes: bulging disc, arthritic bone spurs. People can live life without knowing they have various bone spurs due to arthritis. But if the bone spurs have a way of impinging on the nerve or spinal cord, it's going to show up even on your basic x-ray. That's how bad they can be. And that can cause an impingement on your nerve signals coming from and going to. And it causes a compression, for lack of a better way of saying this, the narrowing causes compression and therefore the stenosis. So symptoms, common symptoms: pain, numbness and tingling. So abnormal sensations, pins and needles, weakness in the affected areas, weakness, maybe a pronounced weakness or only slight weakness. And we compare, when I worked as a neurology nurse, we always compared right and left hand side. Is one stronger? Is one appreciably weaker, slightly weaker? And that was a way we always compared right and left. Treatments, okay. The most basic, without doing surgery, physical therapy to help strengthen structures, especially muscles, and things like posture and how we move, how we sit, how we walk. Rest, that's a big one, rest. Medications as well. Can be anti-inflammatory medications, muscle relaxants. It can be short-term opioids or opiates. So medication serves a good purpose in this. I want to say ice and heat also play a part, even though I didn't include it there. It also plays a big part at attenuating your signs and symptoms. Injections, and what I mean by that mostly are epidural steroid injections or nerve blocks. like sacroiliac nerve block, those kinds of things, are also other ways of treating that. Last resort, when everything's exhausted, is surgery. That is a last resort, not a first resort, unless there is, major complications and possibility that if we don't do something about this quickly, you might lose permanently some part of motor or sensation.
Are you going to go over which comes first, ice or heat?
Oh, yes. I'm sorry. Kevin asked which would come first as ice and heat. Usually ice comes first. Heat is good for loosening up muscles. Ice is good for mainly diminishing the inflammation and decreasing pain, basically. Ice is great at the beginning or onset of your injury and symptoms. And then heat plays a part later on in helping to loosen up the area and maybe help bring muscles and other tissues around the injury, make them a little bit looser. And maybe you need to have that looseness a little bit if you're going to exercise around that. Now, here's what spinal stenosis looks on an MRI. And this is in the cervical region, which is the neck. Okay. If you look closely at this, we're looking at maybe C4, possibly C5. You see this intervertebral disc here. There is what appears to be a slight bulge, and that could be material from the disc. Now, also, it looks like he has a bit of a bone spur here, which is a bony, it's a bony projection that usually comes about due to arthritis. I would say nearly all of us up here of a certain age have bone spurs, and we just don't know it, but we do. We have those bone spurs, and that's extra bone growth that's in an abnormal direction.
Question about bone spurs.
Yes.
So they don't form smooth bumps. They
No.
form jagged bumps, right?
They form abnormally, some jagged, but yeah, I would say most of them are an abnormally jagged look to them.
So then they rub against a nerve and
They could, or the spinal cord.
or the spinal cord.
Or the spinal cord, yes, yes. And that can cause narrowing and impingement. It can cause all kinds of symptoms below that level. And so knowing this is high up, they want to do something about it before, the symptoms and signs become a lot worse. And I say this is one of the best pictures I found online that exhibit what spinal stenosis really looks like. Now, here's another good one from a different source, but the arrows point to the area where there is spinal stenosis. And this individual has it on 3 levels, maybe 4. And you see there that look where you don't have that nice, completely clear spinal cord running. You see impingements right here, here, and here. And you see these bulges. See these bulges here? That's abnormal. And these actually have maybe a little bit of abnormal bone spur projection. And you may have inflammation around here too. Inflammation plays a part of squeezing on the cord and outflowing nerves. So you have a ruptured or a possibly protruding discs. You have bone spurs. And then you have inflammation, which causes an impingement or a squeezing on those areas. This is a classic view, a very good example of that spinal stenosis. Yeah, I would say it probably hurts really bad. Now, there is a little differentiating between stenosis and a herniated disc. You will start usually with a bulging disc, and then it can easily turn into a herniated disc if something is not done about it. Now, this is a disc prolapse, which means it's extruding out of its normal place. Shouldn't be doing that. And this is at the level low in the back, right around C4-5. Now, this is a common condition too. With a prolapsed disc, herniated disc, you're going to have that extrusion of the nucleus, which is the inside part, the jellied part really of the fibrous intervertebral discs. And so when this happens, this soft inner portion, as well as the annulus, the outer portion, has to have a place to go. Path of least resistance is where it's going to go. And that is in toward the cord. All right. And this is going to cause pain due to compression. So that herniated nucleus pulposus is the inner gelatinous part of this fibrous disc. And you may not know this is even going to happen. This is like something you may not even know that you are working on a bulging disc. You may have a symptom here, a symptom there, until something happens and boom, that disc begins to extrude. Now you have a big problem, okay? So again, it follows a pretty good pattern of bulging disc, injury of some sort that causes a bulging of the disc. Then symptoms begin from there. And when you have a herniated disc, the worst case scenario, you're in pain, you can't feel, maybe down one leg or the other. So the sensation is definitely, I can't feel that area at all. Maybe since this is down here in the lumbar area, you could lose bowel and bladder control.
Great.
That's the worst case scenario. And that's important to get taken care of as soon as possible, so you don't encounter that. And usually treatments initially are what you would do with spinal stenosis, except in many cases, this is going to require surgery to correct. That means they have to go in, they have to remove maybe the laminectomy, a part of the bone on the side here. Oh, shoot. Well, this is a good, let me go back though. It's the part of the bone that we're not seeing here because of the side view. There's the lamina, and you have the articulating parts of the vertebra that actually communicate and help movement. There's a cutaway of that in order to get at the disc, the offending disc, remove those parts surgically, and then perhaps putting in, maybe, it depends on the severity of the injury. They might try to put in hardware. They might try to just leave it alone. The offending disc is gone now. Let's leave it alone. But a lot of times they'll resort to, I want to say, more drastic measures. In other words, adding hardware to correct this. Because if this gets worse and it collapses, then you're going to have a whole different problem, because this structure is going to change and you're not going to have the nice curve anymore. You're going to have more abnormal curves. Because if you correct something, or if this deteriorates at one level, the levels above and below are going to take on loads that they did not have before. So, this is just a nice graphic here of what happens with a disc that herniates. And the disc could herniate in both directions and cause a stenosis here of our cord. And here you can see what happens, because when you get a herniated disc and they have to do surgery on it, there's a possibility that that disc is going to shrink some. And so again, anything that happens at one level is going to affect the levels above and below. There's no escaping that. So you can see too, if you have a shrinkage, guess what else? These outflowing areas, they're going to shrink too. And that's why you see like a red area here, you're going to see impingement on that outflowing nerve. You're going to see swelling, you're going to see inflammation, changes in the structure of the bone and how it moves at this area. Again, your only option may be a fusion surgery. So if you look at this, this looks drastic, but this is, there's two different interventions going on here. Pardon me. One, you have a kind of laminectomy or surgery here that requires moving some of the bone, the lamina here of the vertebra, and maybe they will insert, after they're done removing the offending disc, maybe they will insert some hardware along here, or maybe they'll just leave it alone if it's not too severe. So they call that a laminectomy and discectomy because they're removing part of the bone that's maybe going to be part of the problem. So they'll cut it away, believe it or not, and they'll remove part of the disc. So it's a lami and discectomy. It looks kind of graphic here and simplistic, but this is what they're doing when they get in there. Now, the other thing they might do is actual fusion. Now you see how this works. You have a normal spine here. Oops, I have a very severe herniation going on. And the best way to take care of that is to remove that herniation by possibly removing the offending disc from this direction or from the rear, from behind, and then maybe adding a fusion of your own bone, or it could be donor bone. Then you see the screws. You have a rod connecting two screws that are both going through the main body of the above and below vertebra. Now, that is fairly typical. They do a lot of these kinds of surgeries, but we've come a long way with these surgeries in the last 20 to 25 years. They can do some of these with a minimally invasive. Instead of making a long incision, they can do it through percutaneous holes, and they'll use the equipment that way to put both the screws and their rods in without making a very long incision. Now, it may sound a little barbaric, but it's far better than having a very long incision.
It helps with recovery and minimizes infection.
Yes, it does help. Kevin says it helps with recovery and minimizes infection, and that's exactly the reason why they've moved in that direction. So here is a scoliosis. Now, this is an abnormal curve. As you can see in presentation number 1 here, it's an X-ray, a very abnormal X-ray. Now, if you think about it, everything's going to shift from the rib cage to all the viscera. I mean, I'm talking about organs, lungs, attachments for heart, organs, etc. All that is going to move in clearly the wrong direction with somebody with scoliosis. They're going to have trouble breathing. They may have troubles with, this is compressing the heart. This is compressing other organs here from liver, kidneys, etc. Because this is a hugely abnormal curve. Okay, so this is the before picture. Now, this individual has undergone very, very extensive back surgery from nearly the top, where I want to say where the shoulders are, all the way nearly to the bottom where the tailbone is. And basically, this is the only treatment you can get to correct something like this that you've undoubtedly been living with for a long time. The scoliosis, it's pretty evident early on when you're younger. And when bones are still growing, developing, et cetera, and you're aging, et cetera, into adulthood, this curve, this abnormal, where's my pointer? This abnormal curve gets worse. It does. With time and age, it gets worse. And so it's extensive and risky. But you can see here, this is the same person afterward. And you can see clearly a lot of changes for the better. The lungs, maybe now you can see here, look at what's happening to the lungs. They're compressed. maybe they're not able to take a really good deep breath of air. Here, the lungs have had a chance to expand back into their normal regions. Same with where the organs are placed, including the heart. Now this has more of a, normal position within the thoracic area. And that's my point in showing you scoliosis and the corrective surgery, is that that condition is, dangerous to the individual who has to live their life with it. And here's an example of some bracing that goes on. And yes, especially directly after surgery, you'll have to wear a brace. And when I had my fusion surgery 22 years ago, I had to wear a brace for a little while as I was recovering. And I still have the hardware in my back as a souvenir of what happened to me then. But bracing is very important in helping to maintain proper curvature. And they'll use braces, for goodness sake, even if you haven't had a surgery, to help with some of the correction and to help, in the healing process of that injury, wherever it occurs, usually somewhere down in the lumbar, lower back. Now, compression fractures. This is where, as we age, we have to worry. Compression fractures generally happen due to conditions of the bone, osteoporosis, decalcification of bones, severe arthritis. In any case, the bone integrity of the invertebra begins to crumble. As you can see from this picture here, there are fractures. And I compare that to when I, walk on concrete or sidewalks, how you can see all kinds of cracks and fractures. And I thought this is a good illustration for what's going on with individual vertebrae. It has that appearance: cracks, fractures, fissures, a weakened bone. And what happens when this happens? If it gets severe enough, that bone will collapse. The entire vertebra will collapse. And then you're going to have cord problems, you're going to have nerve problems as well, and stability within the entire region above and below. Okay, so I think I got this picture and captions from Johns Hopkins. Yeah, in general, they say if you're nearing 60 or over, these are some things to watch out for. But there is ways to treat this. There are ways to treat this that are minimally invasive, in fact.
Is there anything that we can do day to day?
Well, some things you can do. I know that diet feeds into this, as well as, I want to say, gosh, some of it occurs as a natural result of, wear and tear over a lifetime on your bone. But if you have osteoporosis or osteopenia, which is a mild form of osteoporosis, your bones are basically, for lack of a better way of putting it, are weaker and maybe more prone to fracture and breaking. And so a lot of these individuals, the condition for them is very advanced to have vertebrae looking like this. And some of these individuals have more than one looking like this. So what happens, if you look at this on a cutaway, this is I think this could be a CT cutaway and not an MRI or an X-ray. But you can see what happens here. It's a total collapse of that bone. And I want to say that just the vertebra itself, and you can see here's the spinal process from the bone itself. You can just see the collapse. And what's happening up here, if you look closely at this, you can see that this person had degenerative process going on. You can see the bone spurs and abnormally shaped vertebrae, okay? This one is one that was one of the weaker ones, and it just collapsed. Where the arrow shows here is where that bone collapsed. So individuals at the greatest risks of this, there's two groups: people with a multiple myeloma or a bone cancer, an aggressive bone cancer, something involving the bones, are at greater risk for fractures in that area. Okay. So cancer increases your risk, certain kinds of cancers. It's usually your myelomas and lymphomas. Okay. And then if you're over the age of 50, you're white, you're Asian, you're at greater risk. Yeah.
Thanks a lot.
Yeah, it's not very much comfort, I would think. And if you're peri or postmenopause, you're at greater risk. Now, if your nutrition and your dietary, I want to say your nutrition and dietary status is not good. If it's poor, you are also at increased risk. If you're a smoker, yes, smoking just increases your risk for everything. You know, you name it. We used to teach patients as they were going home after spine surgery, and they're smokers, we got a lot of them. Look, do not resume smoking until the wound is healed, okay? Until you go in and you get the A-OK from the doc, not to resume smoking, but, you know, hey, this looks better. It looks like you're healed now fully. Then without saying it, you can go back to your smoking. I don't think it's a good thing, but we used to say, look, don't go in a hot tub and soak. Infection. Don't start smoking after your surgery here, because smoking causes vasoconstriction, and it will decrease the amount of blood flow, oxygen, and nutrients to that part of the body. This is just doing everywhere in general. So this one I got off of WebMD. .com, compression fractures. This is a good resource. And now the treatments, yay! They have a couple of approaches. Common is what's called vertebroplasty. And what this is that it's minimally invasive. They have to go through the back to get into the area that has the fracture. And you can see this hasn't totally collapsed, and they can only do this if the bone has not totally collapsed. What they'll do is they will insert what's like a cement or a glue, maybe a little bit of both, into that area. And what happens is it fills the cracks, for crying out loud. It fills the cracks, stabilizes that bone, and helps maintain strength in that area. And it's usually pretty successful. You know, if there's a deformity or something else as a result, of course, it's not going to necessarily correct that. There may have to be something else involved surgically to do that, but it keeps the bone from, I want to say, collapsing, crushing, breaking. So I've taken care of a lot of patients who've had vertebroplasty, and it works. Good. The other one, this is another minimally invasive procedure, is called kyphoplasty, okay? And this involves very similar approach in surgery to the vertebroplasty, only in this case, if there's enough of a bone and structure there left for them to actually insert an inflatable bone, I want to call it a balloon, or it's like a supporting balloon, in order to bring, I want to say, give better form or return the bone to a better form. They'll use this technique, and then what they'll do is they'll inject the material into that structure that they just blew up and gave form to, and that will solidify and also harden. It's like a resin. I don't know, it's not a super glue, but it's a resin of some sort that they put in there to help, if it's possible at that point, to bring the bone back to a more normal looking state of affairs. Now, this shows like an ideal kyphoplasty process here. It's like, wow, it almost returned to normal. And not in all cases, but it will restore bone height in most cases, which is better than having a crushed bone. You see how that works? And in this case, it looks like the crushing of the bone is happening anteriorly instead of posteriorly. You can see where a lot of that is happening, and they just simply go through same process, and it is able to bring the bone back to its height and also maintain strength and structure.
I wonder if it's like the same thing they use for teeth.
You know, you know, that's a good question. I don't know. I remember accompanying my patients several occasions. They went to interventional radiology for the procedure and trying to pick the doc's brains while he's doing the procedure. So it achieves stabilization. It removes, well, by removing parts of the broken bone for one thing. So they have to actually go in here and they have to remove parts of the broken bone that can be removed. And then replacing that with usually with a cage or a plate in front, if necessary. Now, I'm getting to that. I'll get to what a cage and a plate looks like, because sometimes they can have this alone. Other times they will need another supporting structure in between this one and this one to help with stabilization. It could be in the front. It might actually be in the back. This from the Cleveland Clinic, by the way. So this is typical hardware, and I mean typical in that they still use it. This is called a back cage. Now, why they called it a back cage is because they put inside this device bone, your own bone usually. Okay, so there's a bone matrix to this, and they remove the entire disc, the entire thing, and they put this cage in with your bone in it, and it fuses, and it forms a permanent fusion. It's got your own bone, and it's going to fuse with the rest of the bony material above and below. This back cage will not move. Okay, it is part of the stabilization and fusion. On the other hand, this is another type of back cage with an or a type of inner body fusion. That's what this is. Inner body is because it's in between, in between these two vertebral bodies. That's why they call it inner body. And these screws are there to permanently keep it in place, provided that the bone above and below are good bone to go into. So they have a way of actually surgically placing this in between the vertebra and then making sure that these are actually mechanically screwed into the bone above and below. Now, here are two other techniques. And this is sometimes including a back cage, sometimes it doesn't. In this case, you can see here one type of fusion with a back cage. And you can see here that this individual had both anterior and posterior fusion. And this is a biggie because this one is very extensive. They have to go in through the lower abdomen and they have to pull the contents out in order to get to your spine. So they have to move everything aside. And that's very risky, but you know, the docs have been doing it for decades, but it's risky.
Yeah, my brother had that thing.
So you have a fusion from that area too, yes. And Kevin said his brother had this procedure done. Usually the recovery is a little longer than simply having it done from the back, but that spine is also going to be more stable from both sides. So you can see the screws and the plate, or the screws and the rods in the back. Now, this is specifically showcasing inner body fusion and back cage, because this is not something that incorporates, I want to say 1, 2, 3 levels. This is basically doing the same thing, but you don't have a continuous plate here like we do with this. There's a continuous plate. And then the back cage looks a little different there than this one does, but they both incorporate that back cage. This is another technique, procedure, and I have to tell you with these things, it's going to depend on what the surgeon prefers. There is always a representative in the OR suite that The doctor prefers this equipment. The rep is going to be in there and is going to provide everything the surgeon wants, which is like it's like for people who have never been in an OR suite and see these things happening, they'll be like, well, what's this dude being in? What's this dude in here for? He's the representative. He has all the hardware and tools this doctor needs to do the job. So posterior, here's a better view of what's really going on. I won't linger on this, but you can see each one of these individual hubs here is a screw that has gone through the pedicle, which is part of this lateral process here on each one of the vertebral bones. This is solid, and this is why the surgeon prefers to go through that, and he goes into a solid vertebral body, all right? This whole area here is just bone. We don't see the disc. And so he's going in as far as he can and is safe and is able to make a permanent, I want to say stable connection there, because then he is going to move rods into place. You can see how these connecting rods will go in to this slot here. It's cool stuff, and I can see it that way only because I've had several back surgeries and I worked on a spinal neuro floor for many, many years. And so the procedure and the process, and I've seen it done on other people. I was lucky enough, docs let me in to see it on a few occasions. Now, this is cervical. And the reason why I show this is because we're talking about a real, I want to say, this area up here in the neck is, you know, you got this area up here in the neck, as they're doing the procedure, there's a greater risk of some harm happening. They might cut a nerve, for instance, a blood vessel, one that leads to the brain, perhaps. They're more prone to cutting accidentally now veins than they are arteries. However, nicking an artery is not something that has never happened. Cutting a nerve or partially transecting one has happened. So this is risky stuff going up here, very risky. And I have one of those too. Up here on the neck, the doc tried to cut on a wrinkle so it wouldn't look so obvious. And he put in a plate that covered basically similar, like C5, C6, C6, C7. So I have something very similar to what's lined up here with the same screws into the plates. And this time I decided not on my own bone from my hip, but they took sterile bone. And if you take a look at this closer, take a look at this. Do these exactly match up? No. This part here is moving slightly forward. And why is that important to correct? Because if you don't correct it, you may do severe damage to the spinal cord that runs through this pathway. And so to stabilize that entire region, the doc decided on a 3-4 level fusion.
I mean, you did that high, you'd be a quadriplegic.
If you got an injury this high, yes. If you survived the aftermath of all of that, you know, because, oh my God, that's a can of worms. I could talk about that too. But hey, and a nice graphic picture here, this is what it looks like. They have cut away, including, you know, fascia, tendons, muscle, and this is the hardware they put in to stabilize that area. It's very cool. On X-ray examination, this is the 2-part approach, like your, is it your cousin? Brother had done only in the low back. This individual, 2 different individuals, had it done in the neck. And I've seen this and have taken care of patients who have had both fusion front and back. And typically, if you have a fusion front and back, you will have the one done through the front first, not always, and then through the back second. In other words, on separate days. Might be 2 days later, you'll have the fusion through the back part. because you wouldn't believe how long a process it is to do a surgery. Even in the neck, they'll do the same thing. To do an extensive kind of surgery like this, because they're under anesthesia for a long time. This is not something they can get done in an hour, several hours. So you can see the extensive amount of repair takes place. But what happens as a consequence? Less mobility in those areas that they just fused. That is something you're willing to accept in order to have a stable spine in those areas. I was able to accept that I had limitations now, both neck and lower back, and now I can move. So that I could keep doing, so I could keep working. That was my goal. Now, there's alternatives. The epidural steroid injection is a wonderful opportunity and treatment for a lot of people. I've had several, some responses have been better than others. Some responses, I may have only had a matter of 2 or 3 weeks of relief, and then I'm back to square one. Other times, the injected lasted 6 months with relief for that long before symptoms began to return. And there's no way of knowing why or how, rhyme or reason, why it works better this time than it did the other time. Who knows? Maybe there's a difference in your condition the next time they decided to do it. I don't know. There's a lot of theories about that. All right, so yes, they do this before they decide to do drastic surgery. They do. They say, let's do the conservative treatments first. If this isn't emergent, let's do conservative. Now, this is a nice picture here of what it is when they do an epidural, because I'll tell you what, this is delicate, very delicate procedure with a needle in order to avoid going too deep, in which case they may nick the cord or another nerve, or, if they go into a space, they actually might cause a cerebral spinal fluid leak. And I know what that's like because I've had one due to a spinal tap in the lower back. No fun, folks. No fun. So the epidural injection can sometimes be done in this position. Most of the time, patients on their side or their back, and they're consciously sedated so they don't move. They get a little bit of a benzodiazepine called Versed, and then they get a very little bit of a painkiller called fentanyl. And I mean, these are micro amounts so that you're relaxed enough, because a lot of people go into procedures very, very apprehensive, nervous, blood pressure goes through the roof, totally understandable. So they're given a little bit of this through the IV, they relax, but the doctor and the patient and the nurse can still talk to each other, if that makes sense. It's called conscious sedation. Everybody can hear everybody else, trust me. I heard in a procedure when I had one of these done, somebody got one of my, it's wrong, my allergies. I said, no, it's not penicillin, it's sulfa. And I was already under conscious sedation when I said that, which is another reason why they don't give you any of this until you're actually in there, because you have to sign consent. So anyway, I thought I'd show you this because this is a viable option. So PT, of course, my God, I mentioned that before at the beginning. Physical therapy is great. Rehab is one of the first things that they want to take you through pre-surgery, post-surgery. Very helpful, maximizing ability, movement, strength, range of motion. Even after you've had your surgery, they do what they can to maximize that. The goals are, basically these things: mobility and movement, strength, range of motion. 3 big goals from PT. And a nice couple of pictures of what therapists do. Prevention. Right. Common sense. Hey, wear a seatbelt for crying out loud. Don't mix alcohol and driving. Wear helmets. In other words, do the diligence that's needed to be safe when you're doing activities. Home safety, declutter, lighting, secure, anything that can cause a fall. And a lot of these are very applicable as we age. Bathroom falls, non-slip rugs and mats. Can't tell you how many people have come in because they had a slip on a mat or a rug, and boom. Activity, exercise, wear the proper protection, headgear, whatever it is you're doing. Water skiing, off-road biking, whatever the heck it is, lifting weights in the gym. Make sure you're doing everything safely by the book, which is what we try to watch you do here at Cardiovascular Wellness, right? And lastly, evaluate any actions that might pose a risk to you. Again, it goes back to common sense. Because oftentimes we think we can do things we really can't do. So maybe it requires a little bit more thinking. So, okay. And lastly, questions. Oh, I went a little over time, but questions. Any questions out there?
Thank you, Rob.
Oh, was it helpful?
Pretty much. I'm going to have to look at it again.
Oh, okay. We're recording it and putting it up there.
I saw that. Thanks.
Oh, you're most welcome.
No questions, but thank you.
Oh, all right. Okay. If no more questions, we'll sign off. Thanks for coming. Thanks for being here. Oh, hey, wait. Yes.